Welcome, Cheryl Iny Harris, to the Dish with Dina podcast. Thanks so much for joining me today. How's everything going?
I am good and I am delighted to be here. Thank you for having me.
I am delighted too. I just want to give the listeners and now the viewers as well some insight that we are both registered dietitians. A
Mhm.
lot of times I get to cross paths with people who I've only met in the virtual space. And we were just talking about that too, that we had attended an event virtually and now we get to see each other here in this arena. And so I'm very grateful for you spending time and sharing your knowledge and insight into some of the things that we're going to be discussing.
Very much my pleasure to be here.
So let's first start talking just about how you came into the profession of dietetics. A lot of the episodes that I've had in the past with dietitians, it's always very interesting to see if they even knew what a dietitian was or they knew from the very beginning times of going into their academic journey. So what brought that all on for you? And tell us a little bit about how that took you from where you started and where you are now.
Yeah, and kind of, well, I didn't know what a dietitian was, but I did know that I was all about food. So, so my family is originally from the Middle East, both from Iraq and Israel, and so it was all about the food from way back. And so everything, whether it was celebration or consoling or whatever thing, you'd feed people. It was how you express all of the things. And so for me, food was fascinating because food was relationships and food was culture and food was life pretty much. And as I got older and began running track, I noticed that food really affected how I ran. And so when I was a teenager, it kind of crystallized that I wanted to study nutrition in college. And so I did.
And this is something that I think has come up in a couple of other episodes where there is a little bit of a difference of how we implement nutrition approaches, treatments, interventions, whatever the language is that we want to use when it comes to conditions, whether it's the management of, or the prevention of, or the slowing down the progression of something that somebody has been diagnosed with, and the difference between that and athletic performance. And so, can you share a little bit too about just when you were talking just now about how nutrition played a role in when you were running? What were some of the things that you were taught as a runner? Like whether it was the coach or did you even have a dietitian on campus when you were in on a team?
No, okay. So I was extremely type A. So I was getting every single runner's magazine possible, and I was reading all about like how you were supposed to eat and this, that, and the other. And so no one was telling me how I was supposed to eat, but I was trying to learn about, manipulating my diet for optimal. I was actually competing at a national level and sometimes international. So I wanted to know how to run my best. And so this wasn't something someone was putting on me. This was my, type A kind of thing, trying to learn.
This is what I find fascinating, and I'm going to probably come back to this a little bit later on in our conversation too, because as it is right now, well, first let's just back up a second. Will you explain to our listeners and our viewers how long you've been a dietitian?
Sure, I have been a dietitian, I think it's 21 years now.
21 years. So it's fair to assume that when you were doing your running, it was before that, right? In the a little bit more than 20
Yes,
years ago.
yes. So
And so
this would be in the early 90s.
in the early 90s. What I'm getting at, Cheryl, is that back in the day, right? Because I'm from that era-ish too. Back in the day, we didn't have a lot of access to things that were so readily available. And so what you were finding at the time, what you said to was like specific to the athletic trade magazines of that sort nowadays. Could you imagine people going onto YouTube or on Instagram or finding somebody who may or may not really be qualified to administer that information? And so can you share a little bit of insight into, were there any things that you were looking up back then because you were doing your due diligence to be a researcher, to be a great athletic performer? Did anything negate the stuff that you know now as a qualified dietetic professional?
It's interesting because I know some of the things I was doing were not remotely sound. And I do want to be clear. This wasn't things I was looking up on the internet because this was pre-internet. This was me mail ordering magazines because magazines were paper. Um, and they showed up in the mail. And I know that um, the only thing that I think was nutritionally sound was that I needed to hydrate myself really well. But the rest of the things were definitely on the uh, more creative side, but not not based in not based in reality.
Oh, that is fascinating. Because again, you wouldn't know at the time. Let
Mm,
me check who the byline is. Let me see if they're citing any research articles. And
no,
so this is what I want to share too, right, with the listeners and the viewers, that if you are watching this and you're coming from a non-scientific background, so if you're not in the healthcare field yourself, just keep that in mind. Just because you're reading something in a trade magazine or there's a YouTube channel where somebody explains that they are an quote unquote expert in some sort of field, it doesn't always mean that they are qualified to share with you the knowledge and information that they have. So do request, citations or ask them where they're getting their information from, because so many things have advanced too when it comes to performance, hydration, protein, carbohydrates, like depending on if you're an endurance athlete or you're doing bodybuilding or whatever the case may be, different competition things too. So I find this stuff fascinating. And if you don't mind, can we also just dive into, and you can, depending on what your experience was, Cheryl, on your end, but can we dive into a little bit about being conscientious with athletes that they might take some more extreme or restrictive approaches? And so now in your current work, are you working with anybody who is an athlete, or do you happen to see anybody who takes exercise a little bit more seriously, like they're more of a fitness enthusiast and they might be a little bit more restrictive with their diet?
so it's really interesting that you say that. I've gone through, I'm going to say, many career iterations in the interim, and so running is feels sort of like a past life, and so I no longer work with athletes, but I can say certainly there were times where, in retrospect, some of the things I was doing were definitely not healthy. I didn't see that at that point in time, but through the lens I have now, I wish I had sound sound advice, or I had had access to sound information. I have never in my once I got my RD degree, once I got my RD credential, I wasn't working with athletes. I'd already sort of moved into other arenas. But I know that many of my colleagues work with both sports and people with disordered eating, and I know that it's certainly a common thing.
Right. And that's exactly what I was getting at too, where because people might be making weight or trying to, again, enhance their performance in some way, they're not really following the general recommendations of the average healthy adult. And so things could be seen as extreme. And so this is also why we love advocating to work with a dietitian or somebody who is specializing in different arenas as well. So in the case of a sports nutritionist versus somebody who works in pediatric nutrition or whatever the case may be. So I want people to just be aware that just because somebody is a dietitian or nutritionist, they may or may not be super deep diving into that particular field of expertise. And so you might want to look a little further and see if you can get referred to somebody who does specialize into something that you're curious about, because we don't want you to suffer the consequences of restrictive dieting or ending up with any kind of disordered eating habits or patterns. So Cheryl, share with us now, kind of, going a little bit forward into the current world in which you are. What is a typical week in the life of you? What kind of patients are you seeing? What are the roles that you play? What kind of work do you do?
Sure. So, uh, fast forwarding, I ended up developing GI disorders, and that became my passion. And so, I work with people with GI disorders and pain conditions, which for me is absolutely fascinating. And so that is the world I work in, and for me, it's incredibly fulfilling. When I say digestive conditions, I mean the whole GI tube, which, as you probably know, Tina, is from mouth to anus, and so that's all everything sort of like from reflux and things sort of on the upper end of the GI tract to things like Crohn's and colitis. So anywhere in the GI tract. And in terms of pain conditions, one of my favorite things to work with is something called Ehlers-Danlos Syndrome. And one of the things that often comes along with it, which is POTS. POTS has gotten kind of, I'm going to say, trendy since COVID and long COVID have come along, but it also has been around for a long time. And POTS stands for Postural Orthostatic Tachycardia Syndrome.
When we're trained as dietitians, we have certain books and textbooks and clinical conditions and sort of some overarching general ways to address and treat certain things because we follow this whole nutrition care process. For anybody who's not aware, we go through an assessment, we nutritionally diagnose somebody, then we apply an intervention or a treatment plan, set up goals, etc., and then we monitor their cases. So depending on how severe or how often they're coming in to visit us, or if they have some other healthcare providers they're going to visit, they might see us once a week, once a month, depends on whatever it is that we're doing. So when it comes to, so there has been no less than probably a dozen conversations, I want to say in the last 2 years, maybe, of this podcast, where gut disorders and gut health have come up a ton, whether it's
Mhm.
with dietitians or with other people in the health and wellness world. I find it fascinating, but also incredibly complex and incredibly challenging for people who are managing the condition, but also, too, for dietitians to have to kind of go through some sort of protocol of trial and error with the patient. And it can be kind of frustrating or challenging or isolating, depending on how severe their symptoms are, whether or not they feel like they can't socialize because of it, because they never know if they're going to have a flare up or whatever might trigger them in that sense. And it really is there's such a variety of things going on in every little inch of that whole tube that goes down, depending on where things are landing. Do you see more people more often with certain quote unquote more common conditions? Because I know, I think in the information you sent me, you mentioned maybe something about gluten disorders, even celiac disease too, which is technically, we're talking also like autoimmune conditions there as well. But walk me through if you see more prevalent conditions coming up, and if so, what seems to be the factors that are related, if anything, if you can pinpoint something.
It'll feel like I'll get a bunch of something for a couple weeks and then I'll switch up, but most of the people who come see me have multiple GI issues. So I'll see someone who both has reflux and IBS. A lot of people who have inflammatory bowel disease, which is Crohn's and colitis, also have IBS and sometimes also reflux. So it's rare that I see someone who has just one GI disorder. That would be too simple. Usually people have multiple. And as you said before, in terms of it being, frustrating and isolating, when people are worried about, you know, whether they are going to have to use the bathroom and they're afraid about, can I leave the house? It is so isolating, and that's the hardest part for many people, just the social isolation. Um, and that's one of the things that's so rewarding about my job is that when people are able to both have their pain decrease, but be able to go out with their friends and family again, it makes such a huge difference in terms of quality of life.
Yeah, they feel safer. And this also is a testament to you and also the registered dietetics field in general, because we don't just educate the patients on things, we're helping counseling them as well. So we're breaking down barriers, we're giving them support, we're giving them strategies on how to manage their condition and alleviate any of that frustration. And then the case of gastrointestinal disorders, I mean, we've had conversations about this too, many times in so many of the last years of this podcast, of the whole gut brain axis, that the stress that you're having in your mind is going to be affecting your digestion or the lower
Mhm.
part of your gut, and then vice versa, right? Things are getting all fuzzy and foggy because your gut isn't working properly, and that can in itself can just keep this whole loop happening. So the things that you were taught in the beginning of your career, and then flashing forward now to having more expertise in this particular condition or this particular organ system, I would say, can you share with us too what is a typical protocol that might feel easily understandable by anybody who's currently going through some symptoms of GI issues, and they're not sure exactly what to talk about or what to look for. In other words, not that we, and there's always disclaimer that we're not providing medical advice, but it just helps to understand what are some of the things, the questions that you're asking. How are you diving a little bit deeper with the people with whom you're working to figure out, like, is this or is this not something a little bit more serious? Does this require you to go to get an colonoscopy or
Mhm.
an endoscopy first, or do we just first work along food and nutrition modifications?
That's a great question. And w- a lot of, well, first thing is when I was in school, back when the dinosaurs roamed, one of the things we learned is that we don't know very much about GI conditions. And so, okay, maybe fiber can help, but you really can't do very much for patients. And that's so not the case anymore. There's so much we can do for people. And so from my perspective, the whole world has changed, which is amazing. But a lot of one of my requirements when I see people is that that they're actively working with a doctor, meaning a primary care doctor or a gastroenterologist, because I want to make sure they have been screened for quote unquote red flags or alarm signs. And those are things like weight loss, iron deficiency anemia, bleeding, um, waking up at night to kind of run to the bathroom. Um, I may be forgetting other things. Family history of colon cancer or family history of celiac disease, because it's knowing that when there are signs that there's something, I'm not trying to minimize uh, IBS or reflux or things like that, but there are sometimes signs that someone needs a screening for colon cancer or celiac disease or something that can be more severe and requires the screening of a doctor. And so before I start working with someone, I want to make sure those screenings have taken place so that we're clear to make nutritional changes.
Yes, I absolutely love this. I've talked to you about kind of advocating for the patient, and I don't necessarily want anyone to feel overwhelmed by having to document things in their life. But if you notice patterns of something happening, or you're noticing when this happens, my stomach cramps up, just keep a log of those things because that's data that we're collecting. And I mean, even though we're dietitians, we're also patients ourselves. And so a lot of times I think healthcare providers too might dismiss their own conditions and symptoms, but also just the general population or anyone who's listening to this. If you notice something feels a little bit off, just keep some sort of running log of things that you never know what might be connected to something else or might be tied to a different condition that is also manifesting in a different way. And so the more information you can provide to your healthcare provider, the better. I know I love and appreciate when I work with my patients when they come with a notepad or they ask me to print things out and walk through things with them versus I'm constantly going, am I making sense? I don't see you writing or asking me any questions. Like, why is that? Like, let me get some feedback from you as well. And I think a lot of times, and, correct me if I'm wrong, Cheryl, but I think a lot of times patients just look at us to kind of just say and tell and not necessarily ask for their feedback, right? Like they're just waiting for us maybe to hand them a list of instructions, what to do or what not to do, and then send them on their way. But we're really there to dig a little deeper. And how do you feel that that has also changed over the course of your time of being a dietitian?
I think especially because I have complex medical issues, I have, whether intentionally or not intentionally, come to work with patients with complex medical issues. And so they often have the expectation that we are in this together and we are going to and they have come to learn a lot about their issues. And I have the expectation that I'm going to need to learn from them because they've spent years learning about themselves, and I can't possibly learn that in an hour. So I approach it like a partnership, and most of my patients expect to be active participants, and that's what I want.
I think as I'm starting to see more of kind of like the quote unquote newer generation of not just dietitians, but also the way that a lot of healthcare providers are starting to approach more of this culturally sensitive, patient centered atmosphere. We're learning a little bit more about having, making sure we're listening to people and asking questions. And like you just said, you as the patient have gone through your whole life dealing with whatever this condition is, or however much insight you might have to it. Just because I have a textbook and chapter 17 says whatever doesn't mean that I'm right. Like, there are things that you can correct me or we can work on together. And I love that discussion around having a partnership. And so that's something too that I just want patients to recognize as well, assuming that everybody has proper access and has, the proper healthcare provider that is a good fit for them, that if something doesn't seem right, if something keeps coming up but your healthcare provider is not listening to you and is not treating your relationship as a partnership, then that could be something that you could address or see if you might need to find a different person to work with, because you definitely don't want things to be ignored or dismissed just because that healthcare provider maybe is not as savvy, or maybe a little bit more set in their ways of however, they came up in the system. So we definitely want to advocate for everybody to feel very comfortable with the people with whom they're working. Cheryl, let's go into the other direction now with Ehlers-Danlos syndrome.
Ehlers-Danlos syndrome.
Okay. And pain disorders too, because again, this is even deeper diving into conditions that I never even heard of. And like I said, I just started my dietetic journey 8 years ago. So POTS, I think maybe sort of came up, but I've seen a few patients recently in the last couple of years who've been diagnosed with it, but I don't remember even hearing or learning about these things in some of our textbooks. So guide us through
Oh,
some of that as well, as far as the conditions themselves, like how do you define the condition? And then what kind of direction does it take? Like, what kind of approach are you taking as far as what organ system are we looking at when it comes to helping manage people with those conditions, the pain conditions, as you mentioned?
I've really done my best to put, articles in JAND and other places explaining the MNT because you're right, it's not in textbooks or anywhere else, and it really should be, and it's really important. And at least for POTS, the primary management is nutritional, but we'll get back there. So Ehlers-Danlos is a collection of 14 largely genetic connective tissue disorders. 13 of the 14 are rare. And I mean really rare. So some of them are just, a couple people in the world. Some of them are, one in a million. But one of the types, which is the hypermobile type, and under that little umbrella is hypermobile EDS and hypermobility spectrum disorder, has been estimated at around 3% of the population. So it's not rare, it's rarely diagnosed, which are two very different things.
This is a good way to explain it too. When you think of 3% of, you're talking about American population or worldwide?
Worldwide.
Worldwide,
Um,
right.
and it's knowing that there haven't been enough studies to say, oh, it's exactly 3%. The one study that was done got 3.4%, and
Right.
probably the rate has gone up since COVID.
Right.
So, you know, I can't say with certainty exactly what the number is, but that's the
Yeah.
best estimate we've got.
But I love this in a way, because even if somebody does feel like they do not know what this condition is or how to approach it, especially now in the time of we're all technologically advanced, we have the world at our fingertips. I guarantee you there's a Facebook group out there or a .org website out there that can point you in the right direction and give you resources and providers that do understand your condition. So please know that you're not alone with some of these things. And like Cheryl was just saying, it might feel like it's a rare condition for you, but it's not as rare as you think. It's just not necessarily diagnosed properly. And so okay, so walk me through again kind of the approach that you're taking there, because this is pain related as well. It's food and nutrition. And is it fair to assume too there's medications to suppress like inflammation or anything like that as well?
There are medications for pain, but there aren't great medications. A lot of the treatment is around strengthening muscles, but I'll take a step back. So about 10 to 20% of the population are what's known as hypermobile, which just means they're bendy, they're flexible. But it can be a plus to be flexible. So like the Simone Biles of the world are flexible. Ballet dancers, people who are showing off in yoga class, and there's nothing wrong with being flexible. It's a problem if it's causing pain, if it's causing dislocations. That's when hypermobility goes from being an asset to a liability. So when people are flexible and unstable, like their joints are unstable, that's when people move into sort of like the EDS or hypermobility spectrum disorder kind of space because they can, their joints start being painful. So the diagnostic criteria is having joints that are either not just being flexible, but painful joints or dislocating joints. And there are a range of other diagnostic criteria that go along with it. 90% of people with the hypermobile type also have GI issues. Very high percentage also are diagnosed with fibromyalgia.
What comes to mind for me, just because of how I'm thinking of the human body and connective tissues and things like that too, are we talking about, how, I guess, focusing more on things like vitamin C or protein, or am I wrong in that direction of, macro and micronutrient approaches?
It's really interesting because absolutely, if you are deficient in a vitamin, it's going to be a problem. But so far, there is no diet that can fix EDS, any of the types. So there are some theories. So currently, there are one set of authors in Tulane that believe it's a deficiency in folate, and so far that has not been proven. And I'm really curious in where that's going, but so far entirely unproven. But, it's not like giving high dose vitamin C will reverse or change it because that theory has been out there for 20 years and so far hasn't really gone anywhere, and believe me, people have tried.
Yeah, and that's something to keep in mind too, that it's no fault of the person who's dealing with these conditions, that sometimes whatever you are trying might not be able to fix it. So it's possible then, would the approach be more of utilizing certain lifestyle habits and modifications to reduce whatever symptoms that they're having, just to make it a little bit less painful for them?
Yes, so at this point in time, there's no cure, but the treatment is around physical therapy in terms of strengthening so the joints are less unstable, bracing, um, treatment with things like medications, and sometimes surgeries to take care of joints and make sure people aren't doing further damage to their bodies. Because there isn't a cure, there are times where doctors will say, well, what difference does diagnosis make? And, for many people, including me, diagnosis makes a huge difference because if you're not diagnosed, people just keep going from doctor to doctor looking for an answer for all of these problems. I know it took me 24 years to get a diagnosis, and I probably went to over 100 doctors. Because if you don't know what's wrong, you keep looking. And 95% of people are told that their problems are psychological, which is unacceptable, and causes all sorts of problems because there's no amount of going to a therapist that's going to fix unstable joints. That's just not how things work.
Right. Right.
So it's important that people get a proper diagnosis so that they can actually get the care they need. And because so many people do have digestive issues, that they can get, whether it's nutritional care or diagnosed with whatever GI issues, so that they can get proper treatment, symptomatic management.
Yeah, this is really what's frustrating a lot of times, because like you said, the dismissing of it, or it's all in your head. Go take a shower. You might be depressed or whatever, like as
Yep.
if that's going to be the cure. And but meanwhile, people know, like, deep down, if you've been struggling with something and something doesn't seem right, it's unfortunate that it could take you that long, and it's unfortunate that it could take you that many doctors or that many years to actually get somebody to pinpoint and say, oh, you know what, actually, maybe we should start looking into this particular condition, because it sounds like these are the symptoms that you've been having. So, Cheryl, let's talk a little bit about that, especially like I keep saying, kind of in the world that we're in now, with a lot of social media or
Mhm.
people calling out things, or just having more access to information, whether it's validated or not. But what are some of the things that heat you up? Like, what are some of the things that you would like to address, as far as what gets under your skin? What are some things that you feel might be kind of hot topics right now?
I mentioned one of them in terms of, that diagnosis isn't important or isn't necessary because I really do think that it is. Another important one is kind of like what you were saying about vitamin C. Another one is like, oh, well, people can just take collagen and it'll fix things. There are a ton of really restrictive diets out on the internets to fix EDS and all of the types. And there's no evidence for any of them. The studies that have been done show that 40% of people with the hypermobile type of EDS or HSD have a lot of food anxiety. So they screen positive for something called RFID, which is avoidant restrictive food intake disorder, which means just a lot of anxiety around food. And that's because they keep getting messages that, this food's going to hurt you or this food's going to, cause you inflammation. And so a lot of times there's the idea of like, well, what's the harm in just avoiding X or avoiding Y? Well, it causes a lot of anxiety. It causes a lot of mental stress. It's not a it's not a benign thing when either healthcare practitioners or friends and family say you need to cut out this group of food and that group of food. And if you only just took this thing or meditated on this mountain, you'd be better. I mean, it's really hard on people.
Yeah, that absolutely stresses me out when I hear, especially with healthcare providers too, where they'll give, I mean, a perfect example. I get this a lot. IBS comes up a ton. There's, the low FODMAP approach as well that people have been treating,
Mhm.
but we have to make sure that, and we've brought this up in the podcast too a few times before with irritable bowel syndrome. But my biggest pet peeve is when a doctor will just hand somebody the list of high FODMAP foods and just say, don't eat any of these things. And I'm like, that's not the protocol. That's incorrect. And then that's stressful because,
Mhm.
like you said, so what I find not helpful with that is that, okay, so you've just given somebody an entire sheet of paper or whatever food group you're picking and choosing to remove, and you're not all offering any substitutes. So what is being taken away from this person, whether it is a food group in general or a particular offshoot of whatever, characteristics are in that food group, say, vitamin or mineral specific, is coming out of it, and calories too. So now you've restricted the particular food item or items, and now you've also not given this person a way to substitute how to make up those calories. And just like you said, now there's food anxiety all over that, and that really frustrates me because it's just not, it's harmful. It's harmful in that sense. So I
Yeah.
appreciate you speaking up on that and trying to educate your patient population, but also really having a hand and also trying to increase knowledge and update the information that exists out there for healthcare providers to be able to look at and read. So thank you for that. Thank you for your insight into all of that too. Cheryl, share with me if you don't mind, because as you mentioned before, you too have some situations, conditions that you are managing. What is it that you're doing to manage your own self-care? And what are some of the things that you would consider like non-negotiables, as we call them,
Ha.
right? Like if anything goes on in the day or a week, you have to have these following three things just to make sure you're taking care of yourself.
I do have Ehlers-Danlos. I do also have POTS. I do also have GI symptoms that are totally managed, which I feel incredibly lucky for, which is how I became a GI dietitian. Um, there are a lot of things that I consider non-negotiable. Um, a lot of it is even just around having the time to have the pace of life that I want to have, doing physical therapy things, it just being able to go at my own pace, hydrating well, having breaks, non-negotiable. When I don't take time for myself, I am not very useful for clients. And and I've seen that many different times. I really have found that boundaries are just not optional, because when I don't have good boundaries, how I relate to people is different. It's knowing that even when I do the same things, send out the same emails or make the same, do the same appointments or whatever, my energy is different. Like I just I can't be generous in the same way, because I'm giving from an empty cup.
That is so important. We've talked a lot about boundaries on this podcast, and it's one of those things that I think, as a society, right, we always look towards instant gratification and we're always go, go, go. And especially for in the dietetics world, like we love having the hustler mentality where we're just like constantly putting ourselves out there for social media and cut and spreading ourselves really thin. I'm at fault with a lot of these things too, but it's true. You're absolutely right. It has to be set in place because that's a way that you engage with a relationship with yourself, but also teach people how to treat you as well. Like there are certain times of the day that I will just not be available, or I will not be available on certain days of the week because that's my time. And Cheryl, I don't know if you do this too. Like, do you have certain productivity tools that you use, whether it's like calendars or digital tools or a planner to keep track of all the things?
I'm very much not an electronic person. I just moved on to an electronic system, but in some ways, I try not to be terribly productive, meaning I see I have my sort of like the number of patients I see, and then unless it's an emergency, I give myself permission to just this is what I'm going to do and that's it. And I'm okay. Like there's that I used to have the like I need to maximize my productivity, and now I'm actually very content with intentionally not being productive.
This is a second career for me. And the first couple of careers that I have, I was in project management and publishing, and a lot of things were very specific, like seasonally specific to something, so that we would have very, heavy seasons and very light seasons of things, or things were done maybe on an overlap cycle as well. So as a project was coming to completion, then another one was starting, and it just felt like a lot of overlap. And so I started kind of looking at my calendar and color coordinating things, and I was getting really stressed out at the time. And I still kind of do if I see just back to back butted up against one thing and another, and then it just feels like I've been on for 14 hours straight. And as I'm saying this, I know people who know me who are listening to this are going to be like, yeah, right. But I'm telling you right now, Cheryl, you are my witness. But I have spent the last probably 2 to 3 years really honing in on peace for myself. So people constantly think that I'm busy and I'm not. I mean, I'm a busy person. Like I'll keep myself busy, but no more than a person who works a standard 40-hour a week. It's just mine's a little bit, more erratic because I teach on certain days and I do other things on certain days. But I really will carve out time for me. So what happens is when somebody says like I'd love to meet up or let's go to dinner, I haven't talked to you in forever, when can we hang out? I'll look at my calendar, and if I have more than, say two things going on that bump into, say, like a late night or a weekend is being taken up, I'm not sacrificing another one of those days or nights for myself. So a lot of my friends will think that I'm quote unquote so busy because I can't see them for another 3 or 4 weeks, but I'm really trying to hold that space sacred to myself because I just know, just like you said, there's no like my brain is shot, my body starts feeling the consequences. I feel very run down, and I'm not animated in a way that I usually would be. So I'm not bringing my true self to
Yeah.
these situations. So what's the point in going? And as much as I'm so, so grateful that people want to spend time with me, and I'm always really up for hanging out and socializing, I just know my limitations. So I just wanted to at least share that because it sounds like even though you work in a more analog way and I work in a little bit more of a digital way, I definitely hold a lot of my space sacred, and I just feel like it's me time and I need to quiet down and go to bed at a certain time, and I'm not going to be flexible about those things. Those are my non-negotiables.
Yeah. I definitely hear you there. And I definitely, my sleep is sacred. My meditation time is sacred. Like there are my times that are mine. And I it drives people nuts often, but my phone is off a lot of the time. And I
Yeah.
do not want to be reachable all the time.
Tough. Exactly, exactly. Oh, that's the thing too. So emails, responding to things, just like, having correspondence also, like I put a cap on that also. So I'll set aside, say 10:30 and 2:30, maybe 5:30 every so often too, where I'll just go through as much as I can do within, say, half an hour. And then if I didn't get to you, I don't get to you until the next day. Like that's just it. And so those are things that I'm trying to be really conscientious about too, because I could quite literally just keep like one more email. Let me just get to one more thing, or let me read one more newsletter. And then that also takes up up time too. Cheryl, can you share with us also, if we go more into the professional discussion of where do you see yourself going in the next X amount of years of your life? What other things are
Ooh.
you attending, conferences, like any resources that you tend to really get involved in or want to do for yourself as you keep going deeper into your career?
My dream is going back and getting my PhD. I don't know how this is going to go. That is sort of that is what I would really like to do, largely because there has been so little EDS research, and especially in terms of nutrition. And so I have sort of figured that perhaps I'm meant to do it. And so I've done a little bit of research and publication, and each time I do it, I think, oh, well, I don't just want to do review articles. I actually want to do research. And in order to do that, I kind of need to go back to school. So that would really shift the rhythm of all the things. And so I've been looking into how to do that and maintain sanity. And so that may happen.
Is a traditional PhD track full time, X amount of years? Like what's the investment in there as far as time?
No, it would probably be part-time, and rather than, a few years, it would probably be a longer term kind of
Yeah.
thing.
Yeah.
And most people are much younger, but whatever. And I
Yeah.
have no idea what lies ahead, but I'm always up for adventure.
Like you said, it's in there. It's something that's on the list. If it happens, it happens, and that's good that you're going for that. So Cheryl, as we're coming upon the end of our conversation together, is there anything that I didn't ask you, anything that you wanted to share that we haven't got to yet? Just like last final words of wisdom to anyone who's listening or watching.
So I am doing an upcoming program on Ehlers-Danlos nutrition for dietitians that are listening. And kind of what you were saying before, I always really encourage people, if there's something you think you need or something you think is going on, definitely pursue it and always advocate for yourself.
And I appreciate you saying that too. So this brings me to my final two questions. On every
Sure.
podcast, I always ask a food pun intended question. So it's a two-parter. What is on your plate today, Cheryl? Both in when we are wrapping up, what's the next thing that you are doing? And then what is the next meal that you're having?
Well, probably what's going to happen right after here is going to grab some chocolate. But I'm not really sure what's for dinner, even though I do have to figure that out. I think we're having salmon and broccoli. So I think that's the next baked salmon with rosemary, I think, and broccoli, I think, is dinner. Um, so yeah, but chocolate first because priorities.
And then on your figurative plate, what's the next thing that you're doing or working on, whether it's tonight or tomorrow?
It's a beautiful evening, and I'm just gonna go outside and just really enjoy it's cool enough to go outside, and there's a hummingbird feeder right out my door. So I should just be able to go out and hang out with the hummingbirds.
I think that is beautiful, and that ties up nicely our whole conversation about focusing on self-care as well, allowing yourself time to do things that bring you joy. And I hope you do enjoy that, and I hope you enjoy your salmon if that's what you end up having this evening. So thank you, Cheryl, so much. It's been a real pleasure getting to know you and learn more about you. And I absolutely appreciate all of the insight that you brought as well to the conditions that we discussed today. Thank you.
Likewise, great to be here.